So I'm delighted to be here today and to chair this session with my friend Roberto. So that's a pleasure to be here with you. And we will talk today in this session about drug consumption room. As you know, since 1986, some innovative countries and very pragmatic countries like Switzerland have been able to implement drug consumption rooms. And since this period of time, we have more and more drug consumption rooms in Europe, but some countries, including mine, France, are facing some challenges, and especially political challenges, to disseminate drug consumption rooms. So today we will have some formal presentation, but that will be very short. And this formal presentation will give us an overview about what is happening today in Europe from the past and today and for the future too. But what is also very important for us is to have a lot of discussions with you and a lot of discussions about your experiences, your practices, and all the questions and all the challenges that we have to face. So a large part of this session will be dedicated to discussion.
Today we have actually the pleasure of welcoming this ensemble of people that we have in here, numerous panel. We decided to work a tiny bit with the panel. We have a bit of like 3 blocks a tiny bit. On one hand, we have a bit more looking at drug consumption rooms, more through the lens of advocacy or the future of drug consumption rooms. So we will have Tony Duffin. Tony Duffin is the CEO of the Liffey drug project that was established in 1982. And Liffey was the first service in Ireland to be established on the principles of harm reduction. And prior to working at Liffey, Tony was playing a key role in opening Ireland's first emergency accommodation for young people who ingest drugs, and Ireland's first wet residential service for entrenched drinkers. And also, we have Gillian Shorter, and Gillian is a lecturer in clinical psychology and is the co-director of the Drugs and Alcohol Research Network at the Queen's University, Belfast. And then, she has been doing incredible work, working for more than 12 years, she's a powerhouse, the same than other ones in Lisbon. Then we have more recent developments on drug consumption rooms. So we'll be having from Portugal, we have Hanna Taylor, which is a recent graduate with a master's in global public health policy, who is passionate about harm reduction and drug policy reform. And her background spans research, the non-profit sector, and also like journalism. We have also as well Angela Leite, which is a psychologist. And Angela has a master's degree on deviant behavior and justice, and then she has been working for GAT for 2 years. GAT, for those of you who don't know it, is an NGO working that is mainly made out of activists that works with people at risk of HIV and other viral infections. And then also from Portugal, we have Ines. Ines Pereira is a psychologist at Pinhal, and since 2016 has been working in there, and then until 2021 she has been working in the mobile outreach program, and in the last months has been working in the implementation and the development of the first fixed supervised room in Portugal. And then we have 2 people that bring a bit more of like years, decades of experience of countries that has been having drug consumption rooms. So we have Jorn Dekker, that is working for the Regenboog Groep in Amok. And basically, he's, in his own words, an all-round practical worker in a DCR. So he will bring a bit of information about what has been the history, actually looking a bit from the past. And we have Janine Lanz, that actually has been working in the low threshold addiction sector for more than 20 years. And as a profession, she's a social pedagogue and supervisor at the head of one of the 3 contact and drop-in centers in Zurich. So as you can see, we have many different points, and together also with your experiences, we can have quite a good discussion. So as Marie was saying, we will do very short presentations of 5 minutes. So Tony,
Thank you.
The floor is yours.
Now?
Yep.
Hello. Hi, everybody. Thank you, Marie. Thank you, Roberto. And I am going to represent myself and Eugene McCann, my colleague, who we've done a paper together around this whole thing, but we haven't got time to go into the level of detail I'd love to. It's wonderful to be on this panel. Thank you to everybody for coming along to listen to us all. I just want to tell you a little bit about, in a short space of time, about the advocacy for supervised injecting in Ireland. So just to give you a sense of things, in the 20th of January 2012, Hanna Liffey began to advocate for supervised injecting. What we did over the coming years, months and years, were to build a coalition to communicate, obviously, wider than our usual colleagues and friends to the general public, and to work on a legislative campaign, which I'll come back to all those things. Culminating on the 16th of May 2017 with President Michael D. Higgins signing the Misuse of Drugs Supervised Injection Facility Bill 2017 into law. So there was a success. Post-legislation, we've not been able to open up a supervised injection facility in Ireland. And at the moment, as of July 2019, Dublin City Council refused planning permission for a supervised injection facility at a premises that Merchants Quay Ireland, another NGO, run. And that is still ongoing. This month, there's another hearing around the issues with regards to the planning. So we've had policy failure at the moment, and we'll look at that into the future. So, just to talk about what we did in this advocacy piece. So, we were mobilizing counter-hegemonic ideas, or countering the status quo, the ruling or dominant or political or social context. People didn't agree with the idea of supervised injection facilities in January 2012, and that's what we were trying to counter. How did we do that? Well, we brought evidence together from elsewhere. We looked overseas, and we brought that to Ireland and to explain to people, and we developed experience. We went and I visited Sydney's supervised injection facility. Dawn Russell, the head of services at Hanna Liffey, she went to Vancouver and visited their supervised injection facility there, and both of which helped to develop expertise and to explain further what we were trying to do. In terms of the coalition building and strategic communication, so we looked towards trying to do all the heavy lifting, and Aon O'Riordan, the Minister of State with responsibility for the drug strategy at the time, referred to, they had everybody singing off the same hymn sheet, from the guards, the police, to Dublin City Council, to the business community, to themselves. They were all saying the same thing. There wasn't a case of we are a drugs group, lobby group, and we feel this, and then waiting for the business group to have their point of view. They did all the spade work, they did all the discussion beforehand. So we did all the heavy lifting to bring people along, all the other stakeholders. So that was the coalition building that took time. Communication-wise, we engaged regularly and widely with traditional media, wrote opinion pieces and such, and just engaged really, really regularly and widely, and on social media. And then legalising for change, or legislating for change, was a powerful element of the advocacy campaign. We worked with a voluntary assistance scheme of the Bar Council of Ireland, so barristers, senior counsel. They drafted legislation. It was probably the only time it's ever happened, well, certainly in Ireland, I think worldwide, where outside of the parliamentary process, we were helped to draft legislation, and you can see a direct correlation between the legislation now and this legislation that was drafted and given to the minister. And then just on, I suppose, where we're at now, and I'll just say, I suppose getting the legislation over the line was, upon reflection, easier than getting the supervised injection facility open. Many jurisdictions have experienced delays in opening a service due to, say, NIMBYism, not in my backyard, or planning and other issues. It is frustrating that street-based injecting continues to be an issue in Dublin city centre, and that having been agreed at policy level over 4 years ago, almost 5 now, we are still at best a year or two away from opening Ireland's pilot supervised injection facility. I suppose, is it policy failure or deferred success? And I think, obviously I'm hopeful that it's deferred success. So and in terms of policy, Wells says systematic regulatory failing is endemic to governance. Indeed, policy failing is an ongoing and unstable process. So, you know, the failures that we've had so far will lead to something, you know, where we get injecting rooms open. I'm sure. A 15-year history of the Melbourne case suggests that failure can be generative, so it does happen, and it has happened elsewhere. And I suppose, nonetheless, this idea of failure or deferred success prompts more thoughts about strategy. So is a judicial strategy more appropriate than a civil disobedience strategy? Which leads me to hand over to my next speaker. I hope I did good well on time.
Thank you very much, Tony. And I do hope it is deferred success for you and for Ireland. Good afternoon, everyone. I'm Gillian Shorter, and I'm the lead evaluator for the first unsanctioned safe injecting facility in the UK. And I would not be here, sitting here, without Peter Crikand, who I hope is in the audience, who took this historic step. And if you wouldn't mind joining me in a round of applause, I feel it's very much deserved. Sorry, Peter. In total, there's been over 1,000 injections supervised at this site. We have records for 894 because when the service is busy, there's always a prioritization of support versus data collection, which is as it should be. The context really that we see this van operate is 1,339 drug deaths in Scotland. Every year we break the record in the UK set the previous year. It's year on year, every year we break the record. And over 400 are in Glasgow alone. There's an ongoing HIV outbreak in Glasgow as well. This is another set of the context. So on Overdose Prevention Day, our 31st of August, Peter took the enormous step of purchasing a minibus and converting that into a drug consumption facility. And in coronavirus times too, it can't have been terribly easy. The first injection was then supervised on the 11th of September, and the numbers sort of to the early opening to the end of the year were around 30 injections per month. In January, February time, there were some mechanical problems with the first van, which forced a vehicle change to an ambulance. And this was a bit more fit for purpose. We could see more clients, we could expand the data collected, so I got very excited about this, I'm sure you know. So the key policy arguments we have for drug consumption rooms often centre on important issues like bloodborne viruses, prevention and support, wound or soft tissue care, overdose prevention, treatment referral, and indeed in the van we had 9 overdose events attended to by service volunteers in or around the vehicle. And they involved 8 people, all of which survived, 2 of which were related to cocaine, the remainder opiates. And it's a wonderful testament to the work that the service has done. What we don't talk about as much are the psychological benefits, and as I've said before, I'm a psychologist, so this means a lot to me. We saw the numbers increasing as trust was building to 440 injections in March alone. That's an enormous number that represents that development of trust, that social and physical opportunity for harm reduction and harm reduction related behaviour change, which then has impacts on all those other things like bloodborne viruses, infections, self-care, well-being, just helping people thrive, setting, supportive norms and having somewhere clean, hygienic, and more importantly, friendly for people to go in Glasgow. At the van, cocaine injecting predominated, powder cocaine injecting, a little bit higher heroin use in women, to be fair, and groin injecting was probably the predominant route of injection, again higher in women. So there are real challenges to running an unsanctioned service. It's unfunded, you don't know where money's coming from, you're relying on volunteers, you're relying on donations. There was limited local partner and local organisational support, and holding those stories that you hear from the wonderful clients who trusted Peter and his volunteers enough to come to the service. These are stories of neglect, of abuse, of broken trust, of inhumane treatment in multiple different ways. There are also threats around criminal justice and knowing just how much the service means to those who use it. The pressure is and was and will remain enormous for people who run unsanctioned sites. Unfortunately, as I'm sure many of you are aware, the service did close in May this year. So where exactly does that leave us now? Peter's extraordinary act of courage and self-sacrifice gave us much heart in the UK. And let's face it, a well-needed kick up the behind. To do more, to be more, and to use whatever power we have for good. His conversations with Scottish parliamentarians secured additional funding, admittedly for treatment which may not really be the population who are using DCRs, but that's still great to have as well. And renewed commitments, including a drugs minister who's actively looking for best practice. Yes, this is what we want. Finally, some evidence-based stuff. Yes. So, I get excited about these things. Do forgive me. We also have a new Lord Advocate. Yes. Exciting times. Dorothy Bain, QC, looking at ways around and thinking about the Misuse of Drugs Act in a different way, looking again at drug consumption rooms. There are so many organisations in the UK now energised to play a part. Some things I can't really talk about here. As of this morning, exciting, hot off the press, geeky news for all of you, we have ethical approval for an evaluation framework to pilot a site in the UK. So we just need a site that will partner with us to do that, and we've got it ready to go. Why that's important is it allows politicians to save face. So piloting rather than just opening gives them the comfort that it can close if it's ineffective and puts the onus on the service and the partners who are working with the service to get the right service for the right area. The other thing is health is a devolved issue, and by this I mean Scotland, Wales, Northern Ireland can make laws and decisions about health matters. However, criminal justice is, decisions are made at central government level, and for years that allowed us all to shout at each other and say it's your fault we don't have this and it's your fault we don't have that. So as we start to consider a more health response to drugs, and we've seen some really exciting talks about decriminalisation this morning, this gives us more opportunity for change. And as Peter's extraordinary act of courage made us all this little bit braver, there is so much to be hopeful for, and I hope the first sanctioned site can be opened soon. Thank you all so much for your attention.
Great. Okay, everybody. Hi, I'm Hanna, and I'll be presenting on community perception surrounding Lisbon's mobile drug consumption room. So first, oh, this one's not me. It's another one. A white presentation? Yeah. Sure, I'm Hanna Taylor. Perfect, thank you so much. Okay, so we'll start again. So this is community perception surrounding Lisbon's mobile drug consumption room. So first, just a bit about the research design. So this research followed a quasi-pre-post design with the first set of interviews happening early on into service provision, which began in April 2019 in Lisbon. And the second round of data collection happened at least 6 months after the first stage of interviews. The participants were key informants who either live or work in the neighborhoods of intervention in Lisbon, and they were recruited using a convenience sample in the network of contacts of the team who operates the service. They responded to questionnaires with closed and open-ended questions covering topics of opinions of the mobile drug consumption room, security perceptions as related to drug use in their neighborhoods, and positive and negative changes that they anticipated or witnessed and attributed to the mobile drug consumption room. And then eventually the data was analyzed using a thematic content approach and an inductive method. So there were a total of 29 participants in the first round and 21 in the second round. And they come from 2 neighborhoods, the first one being Arroios, which is more central and more anonymous in Lisbon and is characterized more by people using drugs in more closed settings, whereas the other is Beato, which is a bit more on the city's outskirts and has a bit less services and connections to public transport, and people tend to use more in an open drug scene in Beato. There was a pretty good gender balance in the sample with 59% male, 41% female. And they had an average of 25 years spent in the neighborhood, either living or working, so there's strong community ties to these neighborhoods. And only 10% of the sample self-reported a history of drug use other than cannabis, but when asked about somebody close to them, so a family or friends, almost 60%, 59% reported a history of drug use. So now moving on to the findings, the most important part. There was 100% acceptability in both rounds of data collection among the participants in the neighborhood, and they showed a very high level of understanding of the mobile drug consumption room as primarily a health and harm reduction service aimed at people who use drugs. Visibility was a primary concern among participants. So in the first round, they shared that they desired to see less consumption in public. And in the end, there was a smaller proportion of participants in the second round who reported having seen injection in public in the past month. That went from 45 to 20%. And there were 13 mentions in terms of positive changes that the participants themselves attributed to the service, where they said it's not as common to see consumption in public. Of course, the COVID-19 pandemic passed through the middle of this data collection and really changed the way that people move and see their neighbors and see what's happening on the streets. So obviously we interpret that with a lot of caution. Consumption-related waste was also a priority in that participants shared that they didn't want to find as much consumption-related waste in public in their neighborhood. In the end, only a slightly smaller proportion reported having found consumption-related waste in public in the past month, and there were 6 mentions among participants of having noticed less consumption waste in public as a positive change that they attributed to the service. There's a really notable lack of negative changes that participants said they associated with the service. The only one that they mentioned was more people who use drugs coming into the area, presumably to use the service, and only 2 participants mentioned that one time each. Participants also, interestingly, tended to distance themselves from negative opinions. So whenever they said, for example, this was in the first round, participants would say, I think there will be other people who don't like it because they don't understand. So they tended to attribute any negative opinions or thoughts to other participants. And in the case of the participants who said that more people coming to the area was a bad thing, they said, but it doesn't bother me. So there was kind of this pattern of distancing. And even though this wasn't one of the primary research questions, the data posed some interesting questions about the contact between the mobile drug consumption room and its staff in the community, given that participants tended to talk about the services that are offered just to people who use drugs. They didn't mention the services that are also available to the community, and most people also reported having had only 30% of participants reported having had contact with the MDCR staff. So those are just interesting areas for future exploration, especially as more drug consumption spaces are opening in Lisbon. We think that that could be a fruitful area for future research looking at the community dynamics. And yeah, this was an exploratory study, which is very limited by a small sample size and the effects of the COVID-19 pandemic. But yeah, we think it's really interesting, especially the very high level of acceptability and community knowledge of the mobile drug consumption room. Thank you.
Hi everyone. My name is Angela. And I'm going to present you the preliminary results about our study of client and professional satisfaction about the mobile drug consumption room in Lisbon, Portugal. So, Angela? I'm waiting for my slide. That is not coming? No. Angela Leite. The purple one. Okay, so I will start. So for this study, we wanted to understand the satisfaction that clients and professionals have about our mobile drug consumption room, exploring the strengths and limitations of the program, and also what should we do to improve the services of our MDCR. So for that, 12 structured interviews were made. Were conducted with users of the van, and also one focus group with 3 people, and also another focus group with professionals, with seven professionals that work or have worked in a mobile drug consumption room. About the main strengths, in general, clients and professionals have similar opinions about mobile drug consumption room. They mentioned the hygiene and the safety they feel when used inside of the van. And the safety because, well, it's obvious because they feel more safer because we have professionals that can interview with them if there are, in case of a possible overdose, but also because they are more protected of people that can look at them while using in the streets, so they feel more protected inside the van. Also, our nurse and peer education that work on the van made this educational sessions for safer injection and consumption. So they feel that it's very important to learn how to use drugs in a safer way. And also they talk about privacy because they feel more privacy inside of the van compared when they use in the streets. Also, all participants refer the importance of the relationship with the team and the clients, and this they feel that they have a good experience with the team, and this is a very important factor in our reduction programs. Because of the respect, the non-judgment, acceptance, and this is crucial for people to feel comfortable and come back in future times. Also, behind consumption, we have another services, such giving you material for drug use or social and health support, testing for main infections, and they feel this is a very important service too, and not only the consumption. And in the end, only professionals said something about the mobility of the van. The fact that it's a van, it's easier to go to new locals and keep up with the change in on drug markets because the drug markets are always changing, and it's important that we can go with that changes too. About difficulties, participants say that sometimes they don't use inside the van because they can't consume with other people in big groups, and this is an important aspect for them because the consumption is always experience, a group experience sometimes, so they feel that sometimes is an important thing, and they also feel a little bit embarrassed with other people seeing and looking at them, especially if they not know the people yet. Also, they have some habits like consuming in a certain context or some rituals they have, and it's difficult for them to change. And because of our education session, sometimes it's difficult for them to change their habits. So this is a limitation, a barrier to our intervention. Also, the physical conditions of the van, because the van is very small and only 2 people are permitted consuming inside the van at the same time. So sometimes it's a barrier to our intervention too. And also, professionals mentioned the difficulty of bringing women to the van because there are a gender imbalance, and it's very difficult for women to consume inside the van, but also use other services. So this is a difficulty too. About the recommendations and suggestions the participants. Thank you. The participants made. The more mentioned and the more important one for all participants was about the need of having a space for smoke consumption. This is because inside the van is only permitted the injected consumption, so this is a difficulty too. They also suggest more extended hours. Well, the van is working every day, even weekends and in holidays, but they missed the early morning and the end of the day. So this is a recommendation they made. And also they suggest new locations that the team has considered, and we are working for having new stops, new locations that participants mentioned. But to conclude, we think that the MDCR is not seen just an health service, but also as a great emotional and social source of support that permits to create meaningful relationship with people. So where opportunities are given at various levels, and this proximity of clients and professionals, it's very important to allow access to health and social services, the linkage to these services, and the empowerment of people. So the MDCR is not an health service, but it's much more than that. And well, to conclude, all participants are very happy with this intervention, with the program, but there are so much more to do, so we are aware of this. So thank you very much.
Hi, my name is Ines Pereira. I'm a psychologist in Ares do Pinhal. I don't know if... Ares do Pinhal is a non-profit NGO for social inclusion, which has worked with severe drug users since 1986. In 1998, Ares do Pinhal was invited by the City Council of Lisbon to manage an outreach harm reduction project within the urban regeneration of a shanty town in Lisbon. In 2001, the opening of drug consumption rooms was approved as a consequence of the well-known Portuguese decriminalization law, but however, the first fixed room in Portugal only opened in 2021. The chosen location in Portugal was the capital, Lisbon, and more specifically, the neighborhood Casal Ventoso. Let me just put, okay. Due to the intense drug trafficking activities and the higher degree of drug consumption in public spaces, Casal Ventoso, for that reason, has deficient personal care at all levels in the community and major public health risks, social exclusion and stigma. So, not only we open a drug consumption room, but an integrated support service that has 2 consumption rooms, an intravenous and a smoked, a reception, a coffee desk where we are able to offer some sandwiches and tea with the help of donations, of course, a psychosocial support office, a pet sitting space, laundry and bathroom facilities, nursing and medical consultations. We also have a community team that intervenes in the neighborhood, collecting syringes within our harm reduction practices. In some way, we aim to engage with the community as well as with other users who might not know about our facilities in articulation with harm reduction teams in the field. The main objectives in this service are to promote dignity, health education and safer drug use, enable linkage to care and treatments, reduce public health risks, work the personnel accountability and social inclusion, to promote urban hygiene and reduce social noise in this area. So about the first 6 months of intervention, as you can see, 637 users entered the service, 72 users were screened for HCV and HIV rapid testing, and almost 4,000 harm reduction education sessions were planned. Regarding the user features, the majority are male and of Portuguese nationality, and the average age is 44 years old. About the types of consumption, we can observe that until September, there were 426 users smoking and 91 users injecting. In injecting consumption, the most used substance is speedball. In smoked consumption, the most used substance is heroin. About the distribution of the material that is done in the reception inside the consumption rooms, over 18,000 foils, over 7,000 kits, and almost 6,000 different syringes were given. The users report that they perceive the DCR not only as a consumption room, but as a support service that increases the adherence to the service, which has made the users prolong their stay, not only in the space, but with the team. In a short period of time, people already demonstrate a sense of belonging to the space, bringing their personal and significant objects. We were aware that the creation of the DCR in such a neighborhood would certainly be a complex task, subject to social controversy and resistance from the local community, in line with past initiatives such as a decriminalization of drug use, low threshold methadone programs, or needle exchange programs. It was possible to minimize the impact in the neighborhood through community involvement by the community team prior to the inauguration and on a continuous basis by the fact that is visible the decrease of public consumption and social unrest. For the final remarks, I would like to talk about some of the barriers within the DCR. Most of them were a consequence of the high number of users that entered the service, superior than expected in the diagnosis. That higher number leads to a physical space limitation, so an adjustment could be performed in the space allocated for each type of consumption, as the smoked room should have more capacity, allowing for more simultaneous users. The resources to acquire food and essential goods are scarce. Although we have access to many donations, it is very rare for us to have enough supply for our needs. Due to the limited funding of the project, another one of our challenges is the lack of human resources within the team. And that's it. Thank you for your attention.
Hello everybody, my name is Jorn Dekker and I'm from the Netherlands. I work at AMOC. This is a drop-in center for homeless people in Amsterdam. I'm sorry, I didn't talk to this group of people in like 1.5 years, so I'm kind of a bit nervous. Anyway, so we work with European citizens in AMOC. AMOC is part of a bigger organization called the Regenboog Groep, and they are focusing on homeless people and basically people in some difficulties like psychosocial problems, etc. For now I will focus on the drug consumption rooms because this whole thing is about drug consumption rooms anyway. Since 1998 there are drug consumption rooms in Amsterdam. We have 3 at the moment. That's Blackawatra, Prinshof and AMOC. Before these actual drug consumption rooms were there were some forms of like illicit drug consumption rooms in squats or in social places where people could get medical attention or social workers or whatever, but it was never said that these were drug consumption rooms. There was people used there, but it was not official. Because drugs in most parts of the world is pretty much illegal, police raided these places and closed them down eventually. Also because of public nuisance, because of criminal activities around these buildings. Eventually, around, so to speak, 1998, then these people who actually closed them down, they asked to open these places up officially. So that was 1998. We're now in 2021. There are still 3 consumption rooms in the Netherlands, in Amsterdam. There are more in the Netherlands. But as we see in Amsterdam, we see a big decrease in amount of clients. People are getting old. There's not really an open drug scene in Amsterdam or in the Netherlands. So basically, I'm telling a really privileged story here for all of you who are working quite hard to get actually a drug consumption room. I really wanted to say that, by the way. Yeah. Anyway, still, we have some challenges. Like I said before, we have a decrease in clients. That does not mean that everybody is stopped using drugs. Some of them did. Some of them passed away because either overdose or they just are getting too old to to live. Great choice of words. Anyway, there are also a lot of people going into these care homes, and there is this kind of thing that people are halfly allowed to use in their rooms, but it's not really a thing. There are some other organizations in the Netherlands, like in The Hague, Woodstock. It's quite an interesting organization. Check it out. It is especially for people who use drugs and have like these problems that elderly people mostly have to deal with, like an aching back, or diabetes, or COPD, because in the Netherlands we only smoke heroin or crack. We don't really shoot it up anymore, except in Amok. That's the last place in Amsterdam where you can inject under supervision. So basically that's the introduction of how it went the last 20, 25 years. There's still some challenges, but that's mostly containing the neighborhood, like staying in the neighborhood, and yeah, the rest is basically fixed. Shall I give the word to you? Thank you for your attention.
I'm afraid. Yeah, I was afraid that moment would come. So now here it is. Hello, everybody. My name is Janine Lanz. I'm one of the privileged people working in a very old contact and drop-in center in Zurich. But other than you, in Holland, I was really surprised to hear about it before, as we talked a little. That you see a decrease in clients. We see an increase in clients after the pandemic or whilst during COVID times. So we have 70 more clients than we used to have before. We used to have 22,000 consumptions monthly in the 3 centers we operate in Zurich, and now we have 27,000 consumptions a month, of which 2/3 would be inhalations and 1/3 would be injections. What we see though is a change in substances. So about I've been running coordinating the consumption room Kaserne for 14 years now, and what we see is a change from heroin to cocaine or to a mixture of it, which brings new challenges for us, but I will get to that later on. Because the time is short, and I shouldn't talk too quick, I was told. I will just briefly go into history, because that's where we came from, and that's the sort of thing crucial to why we are where we are. And it was the big open drug scene in Zurich. I think it's pretty popular and well known. It was, well, a lawless area as it is, violence, gunfights, excessive drug dealings, and I'm not going to read everything of it. Approximately 80 drug-related deaths per year in Zurich, which we can prevent nowadays with our consumption rooms. I mean, 80 doesn't seem to be a high number, but Switzerland being a very small country and Zurich not being a very big city, even if we sometimes want to feel like a big city, it's quite a lot. So many people infected with HIV, many people infected with hepatitis B and C, between 5 to 10 artificial respirations per day. So nowadays it's like one or two a month in all the centres in Zurich. So we really do a good job there, and a very important job. due to those circumstances, the 4-pillar drug policy was introduced, and as you can see, we have prevention, treatment, and law enforcement, and then we had harm reduction, and that was the base on what we could open our first supervised consumption facility, which is still there actually. That's still now, it's been there for 30 years now. So basically the basic services have changed little over the years, because I mean harm reduction stays harm reduction, that doesn't change. So we need the showers, we need the needle exchange and all of that. But what has changed, like the staff became more educated, more specifically educated. And what has really, really improved, and that's very important for the existence of our services, of our centres, is the collaboration with law enforcement. So where like some 20 years ago, so 15 years ago actually, we sort of were like, oh well, the coppers, and they were like, oh, the social workers, and it was more or less like against each other. And nowadays we sometimes have meetings together and exchange about the micro deal, so that it's needed in the centres, because otherwise it wouldn't work, because it's obviously it doesn't grow on the tree. So somewhere people have to get to their substances. So we're very transparent about that in our centres. So I go a bit further because time's running. The main objective, like, is compliance with urban environment, not absence. The relief of the public space, well, that's from the society's point of view anyway. From our point of view, from the inside, it's like to get people off the streets, to get in contact, to build relationships, to get the right and the possibility to intervene, to help, to support. To integrate the drug users, like the people who use into centres where they can get food and showers and all of that. Well, you see, this was we're very proud of our 4-pillar policy. That's why we mentioned it several times. And the cooperation and coordination between social work, police services, and medical assistance services. So we have 3 locations nowadays, and actually, I just want to tell a bit about the last 2 years, because it's been pretty exciting. When the first lockdown came in March 2020, we just closed down due to, infrastructural boundaries, all the 3 centres in Zurich, and we moved to an open space where we had an open air contact centre for like 2 months. It was actually very exciting, because there was nobody in the streets, just our clients, to move like to the outskirts of Zurich, and everybody like being open air. We had those tin barrels with fire in it. We had some clients playing the guitars, some standing around with beer cans. It was like an open air feeling anyway sometimes, and it was for us it was very good just to get the experience that we're able to set up a new centre in a matter of like a couple of hours. And it worked. So in May, like after 2 months, we moved back into the inner city centre, but we only did open 2 of the centres. One of them was a caserne. We set up a big tent, a heated tent, which is huge. So we have like 60 up to 70 people at a time. Yes, I'm hurrying up and hurrying there. I'm getting there. Yes, we reopened. At the 3rd in May. So just quickly to go through it, what we have, what you need in a consumption room are like the spaces for supervised and hygienic use, meeting place and shelter, recreational activities, medical counselling and health promotion, exchange and supply of syringes and needles, information and counselling. But as I have to hurry a bit, what I really find important to go into are the challenges, because I think we face the same challenges. Like, people are getting older, increasing need for long-term care, and at a relatively young age, 40 plus, because you can add like at like 20 years of that, like severe mental impairment due to cocaine use, sometimes dual diagnosis, and those are all things we really are challenged with for the future. And we try to face it with more education and just sort of, as I thought, I think we need to stay agile, resilient, and brave, and just like do what we believe in and keep on going. That's it. Thank you for your attention.
Thank you so much for this fantastic panel. So it was very interesting to have voices about history of Switzerland and Netherlands, because you have a so huge experience and success, and to see what happened in Portugal, and also the challenge that Irish people have to face now. So I think that it was very interesting to see also what are the challenges for the future, and especially the topic of psychiatric access for care for people who use drugs, which is something very tricky now. So now the floor is yours. So if you want to ask questions to the panel, or if you want to share your experience.
Thank you very much. My name is Marianella, I come from Athens, Greece, and I would like to ask you, there has been an ongoing discussion concerning the increase of mental health issues in the society in general, and also in particular to people who use drugs in the last 2 years under the COVID-19 frame. So I would like to ask you if you have observed something like that, and how, if you have observed it, how did you address the issue? Did you have another policy? You did something, a kind of linkage in contact with the municipalities or whatever else? Thank you.
So who wants to answer?
Well, I can try to answer for what we try to do. I mean, sometimes we're a bit lost with that too. What happens is that more and more people with mental illnesses are in the streets because they can't stay in the psychiatrical clinics, which sometimes is good, sometimes it's not so good. Anyway, so they come to our centres, and what we do, we try to integrate them. But sometimes it doesn't work with the rest of the people there. So we face another challenge, and that's the infrastructure. And we are actually searching for better, more adequate infrastructure where we could have like rooms for the people to have a quiet environment with their specialities, with their illness, they could spend their days, and we could support them. But with the centres, as we have them, unfortunately, sometimes really we have to exclude them and send them away because it disturbs the whole setting. And actually, we don't have the solution yet for that problem.
Yeah, basically it would be the same answer as what you're giving. Like COVID also gave this limited access basically in the drop-in centers, and people would be in social isolation way quicker because there's no access to these drop-in centers. So yeah, we don't know where they are or where they are going. They're lost, and hopefully we will see them back. Anyway, that's our experience.
Well, we can talk about our experience. We feel that people were afraid because of the COVID, and many drop-ins and other services close the doors or have limited schedules. But I feel that in the van, people there was an increase for asking for our services because we are a van. It was easy to come with us. So I think we have an increase of our services, but because the service is very specific, because it was a mobile van, it wasn't a drop-in center, so people don't come inside to the van or just one person at a time. But I think it was very, very important. Don't close the doors, and being there for people. Yeah.
So thank you. I have also some colleagues from France who have a very great experience about psychiatric care, and so I will give the floor to them.
Hello, I'm Jamel from Paris. I'm working in the DCR of Gaia. It's a big problem for us too. Most of our users got a mental health problem, and sometimes we have to exclude them from the drug consumption room, so they continue to inject in the streets, and they are taken in pictures by activists against DCR, so it's a big problem for them, but also in our communication with the city hall and neighborhood, so it's a lot of complication for us. But we try to do specific trainings for our crew. All our crew is formed to mental health issues, and also now we have a psychiatrist who is working with us into the DCR and can initiate treatment directly into the DCR. It's not enough, but it's a good starting point, I think.
Thank you.
I would like to ask you, because some of you... Hello? Who was? Yeah, cool. We are going to be intercalating. Many of you have been touching a tiny bit of this through the perspective. Some of you are already working with that, and other ones back on the day. There is the idea of working with drug consumption rooms implies you're touching policy, you're also like touching a bit public opinion, you're touching a tiny bit relationship with the neighborhoods, and all of this refers a bit of like the social acceptability of drug consumption rooms, either from your experiences from the past, how do you deal in the past, or how is the social acceptability nowadays, or from the case of how you're doing it in the future. Could you explain how you're dealing with this? How do you deal with the neighbors? How are you working into like working with this idea of drug consumption rooms around this topic?
Okay, so this is about public perception and maybe winning people over. I think, so as I said on the 20th of January 2012, when we set out to advocate for supervised injecting, I can tell you now that there was a launch of our strategic plan, and one of the board members of the Liffey drug project felt it was so controversial that they couldn't get up on stage with us. That's how they felt, and people didn't really. There was some evidence out there, but Sydney and Vancouver and others had really begun to come through with lots of evaluations and such, and that was the key. The key was to get the information, the evidence together, and then explain it in such a way that it wasn't jargonistic, that it was that it was simple and clear to people, and also spoke to the self-interest of various stakeholders. So what you would do is, you'd look at business groups and you'd be talking about footfall in a city, you'd be talking about improvement and in the quality of the city centre and that kind of thing. And then, of course, if you were trying to win families over, many of the families that we were working with were affected, so they didn't need much winning over. It was their children that were passing away or their parents that had passed away. And having difficulties and injecting in the street and such. So I think there was a lot of work in social media. There was a lot of work in the traditional media to get across this messaging that really, as I say, spoke to the self-interest of various groups of people and explained the benefits. My experience was that the very few detractors from drug consumption rooms. The evidence, you could counter very easily their arguments. The evidence was very clear, and I don't have the quote in front of me, but there's a great quote from Marcus Keane, the head of policy at the time, which sort of said that was really strong about the evidence and how it was almost unarguable that drug consumption rooms made complete sense. That said, moral panic. Media sort of hyping things up and negatively, that kind of thing. So you really had to engage with journalists as well, proactively. My experience with the journalists were that if you gave them the information, if you constructed things well, that they would work with you, and indeed, some of even the red top newspapers really even work, which would be, quite often sensationalist and against these kind of progressive drug policies, would actually come with you. So yeah, that was our experience.
And just really coming back off that, I think it really is about engaging with people's concerns. You know, people have some real issues around, you know, young people and exposure to drugs and exposure to injecting equipment and all sorts of things. And I know sometimes in our field we're like, that's pretty ridiculous, you know, whatever you're saying, you know, they hear all sorts of hysterical nonsense, and really just listening and trying to kind of hide your face a little bit so no one really sees you wincing at the strange things, but listening to that and then trying to come up with a solution. I think one of the things we see a lot in the UK is, why are people just not going to treatment? Why would we open a drug consumption room instead of just putting everyone in treatment? And I think there's a real misunderstanding that what drug consumption rooms are for, and that we're not going to ever achieve the drug-free world that a lot of people are thinking about, and that kind of palatability of for people in society, that people are just not all aiming to get off drugs, and that's not what they're there for. But we can talk about some of the psychological aspects. We can say that drug consumption rooms, without sort of talking about what the endpoints will be, but we can allude to the concept that we're building people up, we're helping to reduce their shame, we're helping them making themselves feel good about themselves and the contribution that they can make, that we're helping them with the opportunity, motivation and capability for change. And we don't need to talk too much about what that change will look like. It could be harm reduction, it could be for some people treatment, but kind of making that psychological argument about those kind of improvements, and that abstinence isn't the goal for everything, I think is a really important thing that we see in the UK. Treatment isn't for everything.
Just, I would like to say that one thing that helps us within the implementation of the drug consumption room is to talk to the neighborhood prior to the implementation. The neighborhood is, they had the drug trafficking activities, drug consumption in public spaces. They need a bus, a simple bus to pass down the neighborhood. They gained that. So to talk to them, and it's a great advice.
Hello, I'm Heidi. I'm coming from harm reduction organization HOPS from Macedonia. I would like to ask something about gender perspective of drug consumption rooms. Representative from Portugal mentioned that the reach, the use of drug consumption room by women is very low. So I would like to know what are the experience from other cities, and if they face the same kind of experience, what do you think, why is that for? Why does this kind of service is not suitable probably for women? I don't know how to define this, but I think you understand me.
That's a good question indeed. We used to have this women night shelter / consumption room in the red light district of Amsterdam, focused on women. It was really only for women, so men were excluded. That's eventually, like I said before, in Amsterdam, this group of users it's really small. So nowadays there is not this shelter anymore, and there is still, I think we have one woman per location in the drug consumption room, and I think that's also a representation of the women who use drugs. It's mostly a man. Also anyway in what I see in drop-in centers anyway, so that would be the first place you go to if you want to eventually go to a drug consumption room in the Netherlands anyway, then the amount of women is less than 5%. So I think it's not per se about a safe space for women as a drug consumption room. I think it's more about a safe space for women or whatever gender, non-binary, that there should be a place for that. Why isn't there any? I don't know. Yeah.
I only had this question like last week, and I didn't know how to answer in Swiss German, so I'll try. We see about 15, max 20% women in our centres, of which like at least half is in a relationship with one of the other users. One explanation could be that women tend more to use meds like other substances they don't have to use in supervised consumption facilities. So that could be one reason. Yeah, well, like that, more men use. What would be very interesting, it would be to know how many women hang out in illegal consumption rooms, like the ones we don't know, the ones we don't get access. And in Zurich, we only get access to people who are registered to the city of Zurich. So there might be a number of women we can't reach.
So there were about 30% women in the injections that were supervised in Glasgow. And this is probably reflective a little bit of the trends of use. And we did see a slight difference in terms of what people were using. So women were more likely to be using heroin, whereas we seem to have a lot more powder cocaine and heroin use in gentlemen. We'd also see that there was a lot more groin injecting as well for women. And again, I think this is a testimony to the kind of safer space. Obviously, if you're injecting in the groin, you're exposing yourself a little bit so you can have access there, and there's a real sense of safety around in the van, and that was a safe place in which those things could be, the conversations could be had, and that people felt protected. I think, you know, there's so much to be said for making spaces for women and thinking about what their needs are in more depth and making sure that that all the things are in place there that are required. We're very much scraped the surface of what we've got in the data, and there's so much more to, but that's just a kind of like some headline thoughts at this stage and need to explore a little bit more in depth. Thanks so much.
So one of the point of the discussions that was very interesting is when from Portugal you talk about the fact that it's very important to talk with the neighborhood. But it seems to me that it is important to talk with the neighborhood, but sometimes when you are living in a country with a very repressive policy, it's difficult to talk with neighborhood, and they can be very aggressive. So that's why sometimes it's more difficult, and in Portugal you are lucky because you have decriminalized drug use, and perhaps it has an impact on the perception that the general population has from drug users, but it's not the case in all countries. So.
Yes, hello. For Elisabeth from Paris, for example, in Paris we have this point, we have one drug consumption room, but it's not enough for the 12 million inhabitants, and we have facing the worst, I think, crack scene these days, these past few years, but it existed for 20 years now, but now it's getting worse and worse, and we have something like 200, 250 drug users settling in places and smoking crack and injecting. And so we want to open other drug consumption rooms, but we couldn't do it because at this time we can't do it because we have politician problem and we have the elections. And also when we are going to see the neighbors, they are just, you know, we have 2/3 listening, wanting to understand and having information, and 1/3 screaming at you saying, just detox, take them away and lock them somewhere, and we don't want to see them down our buildings, our children, all these things. So we are doing the job, we are going to the meeting, but really it's not so easy because sometimes they're just screaming at us, and after when you leave the meeting on the pavement, you can go on with the discussion, and it's more easy because they are alone and they don't have really arguments. They are just screaming. And because also Paris is a very expensive city, and when you want to have a, you know, if you buy there is this gentrification phenomenon, and so they don't want to buy a flat, or they have bought a flat and now, even if it's not true, but it's really the point, and so we can't do anything at this time, and the situation is getting worse and worse, and there are, it's a vicious cycle. We can't get out of it.
Hi, I'm Tuukka from Finland. In Helsinki, the political process around the local initiative has been more or less politically stuck in 2 years. You mentioned, especially the Irish and the UK case, the interaction with the neighborhoods and politicians, media, but what about the police, law enforcement? Have you been in what kind of interaction with them? Are they against, for, neutral? Have you been partnering or tried to do that? Can you comment on that?
I think for Glasgow it's an interesting situation, but certainly within the UK more widely, interaction with the police is really important. And indeed, we have some forces in the UK who have actually put piloting drug consumption rooms as part of their manifesto to get elected as police and crime commissioners. Some are not as progressive, and certainly there's a lot of work, and indeed Release Drugs organisation as well is looking at some of the legal issues around that, so we can make sort of more thoughtful and considered conversations with police officers as they go about their business, respecting what they have to do in their job, as well as what we have to do to look after the people of wherever we are in the UK. So I think those conversations are really important to have, and to have them as informed as possible before you have them, if you can at all.
Thank you. And in Ireland, on Garda Síochána, are very much a major stakeholder in the future implementation of supervised injection facility in Dublin and or anywhere else in Ireland. That said, on Garda Síochána are very clear. They will implement legislation. If that is the law of the land, then but there was no grey areas. The law needed to be changed, and they would implement that. Still, there is detractors are still saying, how will these people magically get to this injecting room, where it is legal to be in possession? And of course, the answer to that is people are walking around Dublin city centre with drugs in their pocket all the time and aren't arrested. And that's how people walk to and from services, homeless services, drug services all the time. And it's just, it's a red herring, It's just ridiculous. So the guards are on board, and I'm sure that when the time is right, there'll be a policing plan, and it'll be very clear how it's going to be managed.
Hi, sorry, Austin O'Carroll from Dublin. Sorry, just a comment on a question. The comment is just about the one possibility why women may be less users of consumption rooms is we've noted in Ireland that women tend to have partners, and often tend to use when there's a partner present. So they will have some form of supervision, whereas that men often tend to be used when they're on their own. So that's one other possibility why women may be less users of consumption rooms. The question is, does the establishment of a consumption room change attitudes in the public and reduce stigma?
The question is, yeah. Yeah, so if an established drug consumption room changed the point of view of like the city council or whatever, basically, or public space, yeah. Actually, I think like within the municipality, within law enforcement, within like the local health authorities, everybody agrees that it is important to have a place like a drug consumption room where people can use or at least needle exchange harm reduction facilities. On a really local level within our neighborhood, like I think they're pretty done with having a drug consumption room in their neighborhood. If you ask around further away from our drug consumption room, if you ask what do you think of the existence of a drug consumption room, people say it's great. It should be there, but not in my backyard. Like, I think that's the whole point in Ireland anyway.
Yeah, just shortly, I totally agree with that. We have the same experience, and currently we're looking for new locations, and it's not easier. It can get harder, because when you really have a disastrous, when you have an open drug scene, everybody can see that action has to be taken. But when it's not visible anymore, which is the case in Zurich, it's not an issue anymore. So we're like, our infrastructure is pretty outdated. So we're really in need of new locations. But it's very, very hard to find something, because, as he said, nobody wants us in his neighborhood.
I disagree a little bit because of my neighborhood where my DCR is. So I can give you an example about the community. A drug dealer took a user who was using in his car and obligated him to use the DCR, for example. So the social unrest that developed from the DCR brought a lot of community does like it, yeah.
Yeah, so maybe this is kind of another example of seeing like the difference in the cultural context of Lisbon as well, and kind of how the community is more ready for these types of services and everything. But something that we saw in the data on the community perceptions is that in the first round, there were more concerns. Like, people were worried about more things happening, but then when they talked about the negative changes, a lot of them did not come to be. So the concerns kind of disappeared over time, at least among this very small sample. So maybe, yeah, when people realized, oh, it didn't change my life or my neighborhood that much for them, they got rid of some of their concerns.
Yeah, because drug consumption rooms are very very specific, but drug services are very difficult to get established anywhere. So it's not that much different. And, just getting any drug service open, running a low threshold service in Dublin city centre with local businesses nearby, it's really important to engage with them. And our neighbours have given us the venue, the pub next door has allowed us to do fundraisers for Liffey and that kind of thing. So it's not all businesses are bad or anything like that. They do appreciate what we're doing. But I do think that something that came up a little bit earlier was the idea that there's one service for the city, one service. That's really unfair on that service. It's really difficult when somebody, you've struggled to keep engaged with them, you run a low threshold service, you're doing everything you can to keep them engaged, and finally you have to give them some time out. And where do they go then? There's only one service. So I think it's really unfair on the service provider, it's unfair on the clients. You need a network of these services, and we should be ambitious for that for all of our cities, that actually I can bounce off of you and you can bounce off of me and somebody can support that person. The other thing, just while I have the microphone, is that the world is small, and some of the things I've said about sort of using evidence to inform the argument in Ireland to get the legislation changed, the reverse is true as well. So I know that in Melbourne there's a review of the injecting room there, and I know that the detractors are looking at Dublin and what's happening there with the school that has successfully blocked successfully had a legal challenge. So they're looking at all this, and so it's a small world, and these things can go both ways, I guess, as well.
Hi, Peter Krykan. I just wanted to, if it's okay, I just wanted to quickly talk about the question from Helsinki. Yeah, just in my own experience here running the DCR in Glasgow, it was engagement with frontline police officers was fantastic. I think now in the UK, certainly in Scotland, the police are becoming much more aware of the failed Misuse of Drugs Act, and how, despite the continuous efforts to sort of crack down on drugs and drug trafficking in general, that it's just not working, that we need a new approach. And also, just to pick up on this point as well quickly about engagement in the local community, Running an unsanctioned supervised consumption facility in Glasgow city centre, driving the van in for the first time, I was a bit worried, in case people were going to chase me with pitchforks, about having a van in the city centre of Glasgow. But what I found was actually starting the facility and getting the facility up and running, the public engagement was absolutely fantastic. Local businesses became very aware very quickly of the benefits of having a consumption facility, and it was as simple as actually just going in and engaging with them. A story I like to tell is I walked into a local business and I said, I'm just in to talk about public injecting drug use, and they said, yeah, we need to get rid of all these fucking junkies and that stupid fucking van across the road there. And I was like, well, that's my van. And we had printed up a couple of simple little sheets, from like the Dr. Peter Centre in Vancouver and, the facility in Sydney and some of the research from Barcelona, and the engagement levels very quickly changed. So I think sometimes it's about going ahead, getting these facilities up and running, and then when the public get to see the benefits of these facilities, public perception changes. That leads me on. I was going to ask a question, but then those two questions, I thought I'll just talk a little bit about that. So it was really to you, Tony. Obviously we've had this government legislation in place now, I think since 2012, you said?
Yeah, 2017.
2017, so for numerous years. And there's been a lot of talk about mobile facilities up here, and not in my backyard, that type of attitude, and legal challenges to a fixed site not opening in Dublin. Is there not a route to open mobile consumption facilities so that you don't have that fixed site, not in my backyard attitude, so you can simply move it to another area if there's any public kickback against it?
Yeah. So the question is around the option of mobile in Dublin. So there are people talking about that, but I think, in fairness, the state is very focused on the fixed site project that they're trying to get open. But I do think that, I don't know what's going to happen, but I do think that clearly everybody knows that mobile is an option. So I don't know what the twists and turns of all this will be, but I know that in other jurisdictions where fixed site couldn't get open, mobiles were established. So it's an option, but I can't say that it'll happen. But one way or the other, we've got to get opened. I mean, people are not far from where I work. You can just walk around the corner and people are injecting down the alleyways. There was a story yesterday at the North Lots in Dublin where people are injecting, and the local community are not giving out. They're concerned for people, and we have legislation. Do you know what I mean? I would have thought that was the hardest thing to change. But actually, when we first, back in 2012, I handed a proposal for the then Minister, Alex White, for a mobile service. But it was premature because the legislation wasn't in place. So, yeah. So, there you go.
So, as we are running with time and we have 4 people who ask for asking questions or sharing experiences, I will let the floor to the 4 last people, and I will let you answer after if you agree with that.
Mart from Estonia. I don't think anyone mentioned drug checking services combined with drug consumption rooms, although this seems like the most logical combination of services. Are any of the facilities currently featured or in planning stages featuring this, even fentanyl strips or something like that? Or are there some sort of barriers that don't allow this?
Hello, I'm an architect and criminologist, so I have a space question to all of you. I'm living in Prague now, and I got a vision of those consumption rooms for Prague. but we live here in a post-totalitarian system, which is very complicated because the people, the normal people, were socialized in a totalitarian system. So they are afraid of everything what's new and everything what's new for the last 30 years also. So my question is, as an architect, do you have an experience of which is the minimum distance between a consumption room and a police station? Not to harm the consumption room, but to give the society the feeling of safety, you know? I was working in the area around drugs and so on also, and in Vienna, so I know that the Viennese drug users are really used to the police, you know? So my question is, what's your experiences in this?
Okay, more questions? Or?
Yeah. Two last questions and after.
Hi, it's not the question. I'm Eva from Amsterdam. Yeah, the Rainbow /Amok user room as well. Just to say about the neighbor situation, because that came back to me. What we did in Amsterdam, actually, we did involve the neighbors by us. So we just we did once a year open house. So we just want to show that our clients, so people which they are using the drugs, they are people like all of us. We are just having the same rights, the same feelings and the same situations maybe in their lives, and that shows by our neighbors that actually they are not so bad people, and they are, you know, we can talk with them, have a coffee and have a food together. So maybe it's a tips for you.
So the last question, experience, and I will give you the floor after.
Yes, regarding the stigmatization, I think it's more complex because we around Paris DCR we have a lot of neighbors supporting us, and we have a neighbor steering committee every 2 months. We had nearly 20 committees, and when we come with a drug user, people are changing their language, you know, not like. And since the beginning of the COVID crisis, we had several propositions of volunteer and from the neighbors. So I think we have some neighbors really against, but a few of them, most of the people, they don't care, or they are willing to help. And I think this problem of the mobile unit, because in Paris they will say, do some mobile unit, you won't have some problem with neighborhood and blah, blah. But in Paris, when we stopped the smoking room, we were up to 450 visits every day. And maybe we welcome a third of the drug user. So it's impossible with a mobile unit to satisfy to the needs of the drug user. Or you have to make 20 or 25 mobile units. And I think it must be pragmatic also. It's not to have a mobile unit, okay, but you need to have fixed place also to.
If I can say something. And even we have really a lot of support from the community. Every day we have mail from people who want to do volunteering with us, who live in the neighborhood. There are a lot of collectives right now in Paris who are motivated to open DCR in the city. So the INSERM study from Marie shows that 80% of the people in France are okay with the idea of a new DCR in the countries. But when you look, the debate is at the national level, and when you look in the media, it's always the negativity with on top of the papers. So it's right now it's a big problem for us. I don't know how we can change this negativity on the social media, because there's a lot of positivity into the community, into the harm reduction services, and it's right now it prevents us to open new DCR in the city, all this negativity. So how we can change it?
Try to find my thread. Sorry. I'll start with the first question. I still can remember about the drug testing. And we actually do drug testing on site, but only a couple of times a year, like not on a daily basis. So it's like 3 or 4 times a year we do the drug testing. People can give samples, they go to a lab, and well, the results return within a week. So it doesn't actually really help for the direct harm reduction at the moment, but still gives us an idea how the quality of the substances is. So, but it would be nice to have in the future, and I think there are some ideas in the heads of some people to just do that. So, and your question, we actually are within the police station. We're in a old military building, and above us, next to us, behind us, and in front of us, there's police. And in the real beginning, like 18 years ago, that was really weird, and the clients didn't want to come because they thought like they were prosecuted when they would be around there. And nowadays, everybody really got used to it. It's kind of weird to be there, but it works.
I also wanted to respond on the drug checking thing, and also later on the neighborhood thing that I also experienced together with Eva. We don't do drug checking on site, but what we do, like once a year, we go to the test service in Amsterdam and we check what the quality is of the heroin or cocaine. Also, if they come with they think they're going to use amphetamines and all of a sudden they are on the floor in a K-hole, then we also go to the test service to make sure that it was not speed. Whereas, yeah. We also had this situation with somebody thinking he was shooting up cocaine, where it was eventually alpha PHP. And to be honest, I've never heard about it. And it was also new for us. But it's like a kind of flakka thingy. Great stuff. Yeah, I also want to respond to about like the connection with the police in the drug consumption room. For us, it is anyway. The police asked to get a drug consumption room, so there is anyway this. Yeah, you work together. Also, when people want to make use of the user room, we tell them like we also work together with police. If something's happening and we have to file a report against you, we will. Also, we have this the obligation to snitch if something like bad is going on. Somebody murdered somebody, for example, and they want to know what the name is of the person who just came in. Then we have to do that. So there's always this collaboration anyway between police. So if it's next to the police station or inside the police station. Anyway.
Okay, some brief notes. About drug checking, I think it's very important, absolutely. We have drug checking in Portugal a few years ago, but only at parties. And more recently, more or less 2 years ago, we have a fixed space for drug checking. And not in a van, but well, maybe this month or next month we will have like a pilot project when so that organization that made the drug checking will come to the van and testing the drugs of people if they want. So I think this is a great experience. Also about the police station. We are very close to a police station too, but I think it's not a problem because people are our partners in the implementation of the project, so they know about us, they know what we do, so they don't get so much close. So I think it's not been a problem. And just to conclude, because our fixed space, mobile space, I think the mobile space, it's very important to start, and it have a lot of advantages, namely the mobility of the van, but it's not enough. The mobile van, it's not enough. We need a fixed space with more services that can receive more people with food, with bath, with clothes and other services. So this is a good start, but well, just to start, because we need more spaces, more fixed spaces in every town. Thank you.
I would just like to underline the thing Angela said about the police. Giving you an example, because before a courtroom appointment, the police brought us to a user to have some snacks, to use the consumption facilities. So there is a comprehension and a sensitivity, of the police authorities throughout our work.
Yep, so on the idea of drug checking, brilliant, love it. And I think if we could get that in our drug consumption rooms, it would be fantastic. And the more harm reduction interventions we can get into one small space, the better. But unfortunately, those sort of things need resourcing. And when you're in an unsanctioned situation, the money may not always be there. But the more the better, I think, with those things. And I think it's a really great idea to integrate if you can. Regarding the police distance and to the consumption room, one of the big things I've taken away from this conference is the importance of the user voice and really asking potential users of your service, go into low areas where low threshold workers are doing sort of street outreach and asking them where they want it, those kind of issues, because if it's not the service that the service users want, they're not going to come to it. So there's no point putting it in an area that they're not in or they can't afford to travel to. So maybe getting that kind of user voice would really help. Regarding the neighbourhood issues, I could probably talk for about 3 weeks. It sounds, everything that you're saying is so interesting, but people want coffee, I'm sure, at some point. But I think the capacity issues are really important for fixed sites as well as mobile sites, and I'm really grateful that you've shared your sort of experiences, but the more capacity we have, it just seems to get eaten up because we can help more people, and then more people want to come to us. So that kind of flexibility and the capacity we have is really important maybe to think about as we plan services or plan opening services more widely, thinking about how it might expand and what we could do to fill that space and serve more people in the community.
Really quickly, just on the policing piece, my experience is that the police listen to other police forces, and if you have police officers that are advocates for drug consumption rooms, then send your senior police officers to go to them and see and learn from them, or invite those police officers here to speak to them. Leave them to talk privately and let them get on. That other whole brotherhood, sisterhood thing they have going on between police forces is a real thing. So yeah, let them get talking.
Well, thank you so much. I would like to ask an applause for this panel that has been we could continue for another half an hour, also like you're still sitting in here, so clear there is more questions, there is more stories. Also there's people in here, we have, for example, there's people from Athens that also have some recent news, there's people from Paris, there's people of places that they are already thinking of opening a drug consumption room, there is also other plans. So this is a good opportunity for you to talk about, exchange and continue the conversation. So thanks a lot, see you around, thanks for coming.